All right. And just some of the students had asked it that weren't able to attend the workshop if we could record one of them so they could take a peek at it. And I thought I recorded the one before, but apparently I did not. So, so we'll record this one. So the goal of this workshop is really just to introduce you to the basics of suturing. You are not expected to be an expert at the end of this, and you won't be an expert. It just takes time. Not all primary care doctors and providers do suturing. So you'll see at the clinic you end up if that's something that they do or something they don't do, or maybe it's a skill that you'll want to bring to your practice. And you can. This is absolutely within our scope of practice as nurse practitioners to do suturing. So I did prepare a PowerPoint, and I'm going to go ahead and share that just to kind of help keep us on track, make sure we're all kind of hitting the same things in each of the workshops. And then I'll send this to Dr. Ross, and she'll email this out to you probably within the next week. So you don't have to worry about taking a lot of notes because it's all going to be in the PowerPoint. I tried to make it pretty comprehensive when I did make that PowerPoint. All right, so I'm actually going to start at the end of my PowerPoint, and then we'll go to the beginning. At the end of the PowerPoint is this algorithm from the American Academy of Family Physicians, which is wonderful. It talks about managing lacerations. And it does start with, is it bleeding? Is it not bleeding? Do you think it's contaminated or not? And then depending on how you answer the questions, you'll just go down through the algorithm, and then you get to the bottom where if it is within our scope of practice to be suturing, it will give you an idea of the type of suture to use for different parts of the body. So I think this was just a really nice, nice screen here. So I'm going to actually back up, don't get motion sick from this here. But with suturing, we have to do a few things before we actually know if we are going to be suturing that area or not. So we want to know from our patient, how did the injury happen and where did it happen? And where, I don't even necessarily mean where on their body, but was it at their house, in their kitchen? Were they cutting bread? Were they washing dishes? Or were they working on the farm? Were they working in the factory? Was it a dirty area where that wound could possibly be contaminated? And when did it happen? So is this somebody that's coming to see you Monday morning, and this is a wound that happened on Friday evening? Because if it happened Friday evening and they're coming Monday morning, we really aren't going to do much outside to clean that wound. And we'll talk about timing in a few of the slides. We also want to know about tetanus status. When did they last have their tetanus shot? Do they have any allergies? And with the allergy portion here, it's really just a lidocaine or epinephrine. But so we want to know, because we're going to be using that to numb the area. And are we concerned about the possibility of infection? Did this happen in a dirty area? And anything else that might be pertinent just based on your patient's health history, where the wound happened, anything else that might be concerning. So our physical assessment, we're going to look at the size, shape of the wound, location. We'll actually measure that wound to see how long it is, how wide it is. Is it still bleeding? If it's still bleeding, we have to stop the bleeding so that we can assess it properly. So maybe we'll just be applying pressure on there. We might have to even use hemostats to clamp little superficial vessels, and that's absolutely fine. We want to make sure there's no foreign body in there, and foreign bodies can be missed about 30% of the time. They actually are missed more frequently than you would think, and an x-ray can be helpful with that. So you might want to get an x-ray done, and then we need to evaluate the extent of the injury. Does it seem like the tendons, nerves, joints might be involved, muscles, bones? If we are suspicious that they're involved, we need to send our patient on to the emergency room, because that would be beyond our scope of practice in primary care. I also have another slide that just talks about when to refer to the specialist. And just for sake of time, I'm not going to read through all of these, but you will have it in your PowerPoint. So with timing of injury repair, there are no randomized controls that evaluate the timing. of our closure, which is really interesting to me because everybody has big opinions on it. And when you are in your clinical practice, you'll see that. And I think what I've heard most often in class, in practicums and clinicals, and is that 12 hours. However, expert opinion really says we can close a wound with suturing, with skin adhesives up to 18 hours after it occurred. And if it's on the scalp, we can go up to 24 hours because the scalp is so vascular that it heals really nicely. We also need to be really careful with our patients that are at increased risk of infection. So that would be our diabetic patient. If it happened in a dirty area, so if it's a contaminated wound, if that wound is longer than 5 centimeters, it is more at risk for infection. And if it's on the lower extremities, those lower extremity wounds, it doesn't seem to matter how good the wound care is, they are just prone to infection. So then a couple other things I want to mention is there is no strong evidence that wound irrigation decreases infection. However, we do irrigate the wound. Common sense tells us we should clean the area before we start suturing it. And what do we clean it with? Tap water has actually been shown in good studies to be just as good as sterile saline. So if the water is good enough to drink, then it's good enough to wash the wound with it. And I like to use that as my comparison. Would I drink that water? If I would, then let's wash the wound with it. If it's on their forearm, wrist, hand, you can just have them put their hand under the faucet and turn it on. That will irrigate it for you and save you a little bit of work. Otherwise, it's recommended 50 to 100 milliliters of solution per 1 centimeter of wound length. Clean versus sterile gloves doesn't seem to make any difference in studies, but this is considered a sterile procedure. So many times we just use our sterile gloves. The last thing, which I am going to add to the slide before I send it to you, is Vaseline is just as good as triple antibiotic ointment or Neosporin, and likely superior. They are equivalent as far as decreasing risk of infection. Neosporin or triple antibiotic do not provide any extra benefit than Vaseline does. And about 15 to 20% of people who use triple antibiotic ointment will develop an allergic reaction to it. You cannot become allergic to Vaseline. So why that makes a difference is when you see a patient back and their wound starts to look red and irritated, it's hard to know if it's an allergic reaction or if it's truly an infection. But if they're just using Vaseline, that's going to let you know it's more likely infection versus an allergic reaction. So we should be recommending Vaseline for any type of wound care. And that is something that has been in the studies for over 20 years in really good studies, but it is something that for whatever reason just isn't catching on in the healthcare community and with our patients. We need to make sure that we are mentioning that. So numbing the area. When we numb the area, we typically use lidocaine mixed with some epinephrine. The epinephrine helps to cause some vasoconstriction and helps with bleeding. So this is the only part that's going to hurt our patient, right? But we want to make sure it's numbed well. So the rest of suturing, they aren't going to feel at all. It is really rare to have an allergy to lidocaine. Once in a while, you'll see it. I've worked in dermatology for over 25 years. We do a lot of suturing. I think I can count on less than one hand how many patients have had allergies to lidocaine, but you can actually infiltrate an area with sterile saline and that will numb the area. So if you have a patient who is completely allergic to lidocaine, like anaphylactic, you don't want to mess around with this, you can use sterile saline. And I was really scared the first time I did it, but it works. I think most often though, I'll see a patient that tells me they're allergic to epinephrine. Many times they're not allergic, they just get that fluttering heartbeat from it. And many times though, it's enough that the patient's like, I don't want that. You can use plain lidocaine. You don't have to have the epinephrine in there, but you won't have that benefit of vasoconstriction. The last thing is you need to be concerned for your patients if they have vascular compromise, if you are using epinephrine. So the biggest thing is appendages and epinephrine, and this is kind of a board question that can get asked. The right answer is don't use epinephrine to your fingers, to your toes, to your ears, to your nose, or to the penis. Those areas can vasoconstrict and actually impact the healing. That's all in theory, and I'm telling you the right answer on boards is don't use epinephrine there. The real answer in clinical practice is we use it there all the time, just to help with the bleeding. And so I just want to make sure you get that answer right, but you can use it just cautiously with your patients. And one example I have of epinephrine is a bad mom experience of mine. I left an EpiPen out. My EpiPen was sitting at my bedside, and my 2-year-old, well, this is a long time ago, but my son was 2 at the time, very thin little guy. He took my EpiPen, thought it was a regular pen, injected it into his baby little finger. So he got the full strength of an adult-sized EpiPen in his finger. And guess what? His finger was just fine. I did bring him to the emergency room because I was worried that maybe something would happen. His finger did turn white for a couple hours, but then it came right back normal. So I always think of that, like, if that little finger can handle that much epinephrine, probably our patient's ear or nose can handle a little bit of it too. You can use topical anesthetics. This is used along with numbing. So these are most beneficial, like if you have a planned mole removal that the patient, you know they're going to have it removed, they can apply that before their appointment. But really, if it's somebody that's coming in with a laceration, we don't typically use it then because it takes about an hour. And you know what happens in that hour? Your patients get really anxious. So it's better just to numb them up and close that wound instead of letting them worry about it for an hour. I included a couple pictures on skin anatomy, which I know is in your dermatology module for health assessment, but I just want to point out where the dermis is and where the epidermis is. Our superficial sutures are going to stick to the epidermis. We're going to have some dermal sutures that will be in the dermis. So when we are doing the suturing, you want to kind of keep in mind, is this a superficial or a deep suture? And with suturing, our big thing is we want to approximate, not strangulate. And I'm sure as nurses, you've all come across sutures you had to take out and they were put in so darn tight, you could hardly get them out. Your office staff will let you know when you do that. And you will do that. We all do when we're first starting to suture. And then you'll just know next time I place those sutures, they don't have to be quite as tight as what I made them. Really, the edges of the laceration should just be touching. They don't need to be overlapping. They don't need to be held real tight, just touching. So let's say we have a patient that came into the clinic. We talked to them about their wound, their tetanus status is updated. We cleaned the wound and we decided this would be a really good one to suture. There are lots of different types of sutures that we can use, and depending on which one you use will depend upon where the wound is, the thickness of the skin, the tension of the skin, and the desired cosmetic result. What I mean by this is if we have a 90-year-old who has a wound on their back, they probably are not going to care what that scar looks like. So it's not such a big deal. If we have a 10-year-old kid in that has a wound on their face, we want to make sure that that's going to heal as good as it can because they're going to carry that scar in a place that somebody can see for the rest of their life. So types of sutures, there's two major types. I'm going to break it into. We have absorbable, the deep absorbable, and then we have superficial sutures. So our deep absorbable, this is our monocryl and vicryl. These are great in high tension areas. They are great for larger wounds. They do absorb on their own, but they take about 6 to 8 weeks to absorb. So during that time, they give a lot of nice strength to the area. If you place a dermal suture, many times you'll use tissue adhesives just right over the top of it to kind of seal that wound. These heal beautifully. And actually in my clinic, we don't use much of our superficial stitching anymore. We've kind of gone more to this. However, neither one is right or wrong. But it is an option that you can use when you're closing a wound. Superficial sutures are divided into non-absorbable and absorbable type. So in our practice kits, we have the non-absorbable type. I think the nylon or Effilon is what's in our suture kits, and these do need to be removed. So we just have to remember that if we're using Prolene, Effilon, nylon, our patients will be needing to come back for suture removal. We can use a superficial absorbable suture, which is like a plain gut suture, and that's great for low tension area. So let's say right above the eyebrow, an area that the skin just doesn't pull much, that absorbs on its own or just falls out in about 5 to 7 days. And in your PowerPoint, I did include a nice chart that talks about the different types of sutures and where you can use them, so you'll have that for your reference. So we're going to talk about placement of the needle within the needle holder when we are suturing, because this is really how we start the suture, and this is going to impact how our suturing goes. So in image A, you'll see that that needle holder is going to be clamped about 2/3 to 3/4 from the tip of our needle. And B and C just show the needles kind of wobbling within the needle holder. So if you are ever at a time where you're placing a suture and you feel like that needle is wobbling, take that suture needle out, reclamp it in the holder. And this shows the needle in the needle holder about that 2/3 to 3/4 of the way down. You'll want to just practice with that needle holder, locking it and unlocking it with one hand, because you will need to be able to do that when you're suturing, because many times your other hand is going to be holding like your pickups or your forceps. So you'll need to be able to lock and unlock your needle holders with just that one hand. And this last image just once again shows proper placement of the needle in the needle holder. If you go too close to where that suture material meets the needle, you're going to bend up that needle, and then it's not a big deal, but you'll probably just need to get a different suture and start again with a new needle. It happens to all of us, so don't feel bad if that happens to you, but the proper placement is really about 2/3 to 3/4 of the way down. Couple other things before we get started is we always want our needle to be entering the skin at 90 degrees. Width and depth should be the same on both sides of the wound. And we want to make sure that we have all of the proper materials before we get started. So that will be our sterile field drape, our needle holder, a tissue forceps, pickups, or tweezers. They are all different names for the same instrument. You might want a skin hook, but you don't have to have one. You'll need a scissors for cutting your sutures. It's a good idea to have a hemostat just in case things are bleeding, sterile gauze, and then you'll need your suture. So we are going to start today with the single interrupted suture. And this is the most important one. This is where we're going to spend the majority of our time during the suture workshop today. These are easy to place. They have really good strength. You can use them anywhere on the body. And I think as far as terms of our workshop today, this is the one I would like you guys to practice most and be able to do. Placing the single interrupted suture and tying the knot are going to be what we're going to focus on today. So this is what our single interrupted suture looks like. And I just like you to know that each individual suture is separate. This is not a running stitch. So one is placed, the suture material is cut, and then you're going to place another one. This image just shows how we want to place it. So image A, you can see the needle is going to go in about 5 millimeters or 1/2 centimeter away from the end of our laceration. It goes down into the skin, also about that 1/2 centimeter, and it's going to come out about 1/2 centimeter on the other side. So it's all equidistant, and you can see in B how nice that closes up then. So I'm going to stop my screen share here. I'm going to have you guys get out your suture material. And I don't know if you already got things set up. if you didn't set it up yet, you'll put that skin material right on this half circle, and then your blue rubber band will go around the outside to secure it. So do you guys have your skin sample there? And all of your materials for it. All right, and then the next thing I'm going to do is just show you, which you may or may not know, just depending upon your practice. Oh, is yours set up there, Emily?
Somewhat.
Okay, let's get yours set up before we move on to our next one. And Grant, is yours all set up?
Mine's a little different one.
Oh, you have a different one there. Okay. I know there's a lot to choose from, and they're all really nice. They allow you to practice many, many times. Or you can always go to the store. You know, chicken breasts are good to practice on. You just have to make sure that you clean your suture materials. One thing when I've done suture workshops in the past is a pork, like pig is good, but the cut that works really good is the hock, and that's really cheap. And so you might want to even practice with that. All right. So I'm just going to show you, this is what the suture material looks like in my clinic. And I think this is probably the most common, where it comes in a sterile container and you open it up and it has paper that's covering the needle, which is nice. So you don't have to worry about getting poked. You'd remove the paper and then you take your needle holders and grab that needle out. I don't have it locked into place. I'm just grabbing it out so I have it there. So I'm going to set this one aside, and then I'm going to open up what came most likely in both of your kits, which is this nylon monofilament suture, which comes in a little cardboard, kind of like cardboard. When you open this one up, you have to be careful, because when you first open it, your needle is right there. So one we have that. You're going to grab that needle. And what I like to do with this is I kind of get it ready. So you can suture towards you or away from you. There's no right or wrong. I was always taught to suture towards me, so that's the way I'm going to show you, because that's just a little easier for me. So now I'm going to load my needle into my needle holder. So I'm going to want the tip of my needle pointing towards the skin, because remember, we want it to go in at that 90 degrees. And I'm going to take my needle holder and clamp it. I'm at a 90-degree angle where I'm clamping it, and I'm about 2/3 to 3/4 of the way down from the tip of my needle. The other thing that's helpful when you start suturing is, remember in that PowerPoint we talked about going about a 1/2 centimeter away from the laceration. So I like to mark that when I'm teaching these suturing workshops, because it gives you a nice goal of where you want your needle to enter the skin and where you're going to want your needle to come out of the skin. You don't have to put the marks on there, but it can be helpful. So I take all of my suture line then out of the little container that it's in. I like to put my needle right over the laceration. And now the tip of it, oh wait, I'm going to back up 1 sec. I forgot to mention to you, our first stitch that goes in for our simple interrupted sutures is going to go in midline. We want it to go right into the center. And then our second one can go in either to the left or to the right, but we're again going to divide this space in half and put in the second one there and the third one over here. And then we're going to go back and forth until it's done. We don't go from one end to the other with a single interrupted suture or the simple interrupted suture, because you can end up with extra skin at the end. That's called like a dog ear or dog flap. It just doesn't work good. So we're going to start right in the center. So now, once again, I'm placing my needle over the laceration, and the tip of it's going to go into that first dot I made. I'm going to tip into the skin to come out on the other side in one motion. So I go in, through, and exit all in one motion. And then the tip of the needle is coming through on the other side. So I could either use my pickups, or I unclasp the needle holder from the needle, and now I can move it over to the other side to pull through my suture. And I'm going to pull until I just have about 1 inch or so of a tail. On the side without the needle, I just have that 1 inch or so of a tail. And then I have a lot of suture material on the side with the needle. And then I like to place that right on my sterile field. So I'm sorry, Emily, I forgot to tell you, make the cut.
Yeah.
With grants, it's already there. So making that cut, mine is about 3 centimeters, and you can do, any length to practice on. The depth doesn't matter either, especially for this first stitch. Our goal was just for these single interrupted sutures. So the depth really does not matter so much into that skin sample. And you'll be surprised how many times you can suture repeatedly in the same areas with these skin samples.
They're pretty cool.
Doesn't make understand. The first puncture goes all the way through both ends, right?
Yep.
Okay.
So I see you have your screen up. Let me watch you put one in, Grant. Let's see how it goes.
Okay.
So, and then I'm going to stop you for 1 second, Grant, because I see Emily. I'm going to have you reposition your needle the opposite way in your needle holder. So you can turn your needle around so that suture and the long part of the suture is coming off on the right side. And then make it so it's facing down, the needle's facing down, and clamp it. And then you're going to start. Is it at a 90 degree? Good. And then they'll start on that other side of the wound compared to where you were. Opposite side. Remember midline. Okay, Grant, let's see you go.
So this is how
That
it
looks
looks.
good.
Okay. And I'm a lefty, so I'm not sure if that makes a difference with needle placement at all, or what side you prefer.
Yeah, everything I say you're going to do opposite.
So
You're used to that probably, right?
yeah, pretty much.
So you may even, Grant, I'm going to take that out there and actually use one of the thinner ones. One of the first 2 cuts that are up there just for our starting.
Okay.
So, like you have that one that looks like a snake that goes all the way across the top. Why don't you just take that one, use the middle portion of it?
Okay.
And now remember, you want your needle to go in at 90 degrees. Perfect. That looks great. Oh,
The one thing I get is kind of hung up in the middle of the skin there.
okay, then you're probably going a little too deep.
Okay.
So when you look at, like, your skin sample looks a little bit different than the one I have, but really you don't, like, the peach colored part, you don't need to go, you just want to go right to the end of that. We don't need to get any deeper than that. Perfect. And so now you could take your pickups or forceps and kind of grab that needle end out on that other side. Many times you need to do that, or your needle holders. And now you'll pull that suture material through. So you just have about an inch or so of suture line there.
Okay.
On that one side. So why don't you guys each try one more to place one more stitch, and then we're going to get to the really tricky part of the workshop. Okay, now that one, Emily, looks like you're going a little too deep.
Okay.
I can kind of see on that one. When that needle starts to get a little lost, like it's not popping through on the other side, that's a good sign that you're going just a little too deep. So now on your skin sample, really kind of look at that peach colored part. I don't want you going too much below that. So you could even grab your forceps to your pickups and just take a look to see, where does that peach part end?
Okay.
And kind of give yourself a little better idea of where that suture should go through. Okay, so probably still just a little bit too deep.
Too deep.
Good, that looks really good, Grant. And I think, like, once you get the hang of it, it's good. You might need to bring your pickups over to the other side and just provide a little tension to the area where the needle's going to come up. Good, good. Swoop it right through there, Emily. And remember, we wanted to exit about a 1/2 centimeter away from that laceration, so not real far away. And I don't know if your needle's bending at all. If it is, you might need to just grab a new suture. That could be part of the problem too, if there's not that curve left to your needle anymore.
Okay.
So while you're practicing that, I am going to just talk about the knot a little bit, because I'd like Grant to be able to start, because he's got a few sutures placed there. With the knot, there are many different ways to knot a suture, and this is probably the hardest part of suturing. We use, what I'm going to teach you today, is the surgeon's knot. And it's very similar to a square knot, except we're going to wrap it twice. Our first knot is going to be wrapped twice around our needle holder. And that's what makes it different than a square knot. But when you are doing your knotting, sometimes people just even drop the needle holders and they'll grab that suture material in their hands and knot with their hands. And that's actually how I was taught to do the dermal suture, was to knot with my hands. So you'll see that online. Any of it is right, but what we're going to do today is practice a surgeon's. That's great, Emily. The surgeon's knot using our needle holder. So unclamp your needle holder there, Emily, and then bring it over to the other side to grab that needle and pull that needle through. So you just have about 1 inch of suture material on that one side. So pull, pull, pull. You're going to pull it all the way through. So you just have about 1 inch hanging off to the side. All right. So now for tying the knot, excuse me. What I like to do is I have my one short end. So my end is going to be facing to the right. Okay. My long end that has the needle is on the left side. I'm going to place my needle holder over my laceration, and I'm going to take the long end, the side of my suture that has the needle on it. I'm going to wrap it once, and I'm going to wrap it twice around the tip of my needle holder. Now it's not way down here. I have it wrapped up here, and you can even just push it with your finger if it's wrapped too low. So I'll show you what it looks like, and then we can do it together. So I wrapped it twice. Now I open my needle holders, but I'm not locking it. And I'm grabbing the tail near the end. And now I'm going to bring the tail towards me, and I'm going to slip the long end of the suture right off the top end of the needle holders. So there is my first knot. All right, you guys ready to try? I'm going to have you take your needle holder and wrap it once, wrap it twice. A couple tips: don't wrap it far away. Don't wrap it like up here. That's going to make it harder for you. Wrap as close as you can to the surface of your skin. So I'm wrapping just one time around, and this time I'm wrapping it to the right. I'm wrapping it towards my short end, and then I pull it through. And this knot won't hold real good. It's when we place the second knot that you're going to be getting a little bit of that knot that stays in place then. And I'm going to peek and see how each of you are doing. All right, Grant, do you think you got that pretty good?
No, I'm not quite sure. I think
Okay,
not
can
quite
you
sure.
lower the camera so I can see a little bit better what you're doing? I'm going to turn off. I have a fan on in here, and I think it's making a little echo. So I'm just going to step away for 1 minute, and I'll be right back. Okay, let me just unfreeze my video here. Okay, Grant, so show me what you're doing so far.
So I'm taking the side with the needle on it, right?
Yep,
Okay, wrapping the thread around twice, right? Okay,
yep. Now I would push that back a little towards your hand because it's too close to the tip. That's going to just slide off just too
good.
easy. And like you could even just use your finger to do that, and it might be a little bit easier to just push it up so it's kind of near that junction of where the needle holders opens and close. Perfect. Now grab the with the needle holders, you're going to grab the tail that's on the other side.
Okay.
Okay.
Mhm.
And now you're going to pull that tail towards you so that the two loops come off the top of your needle holder.
Okay.
And then pull that tight. And you can, it might be easier instead of in your right hand, you have the instrument there. It might be easier to actually use your hand instead of using the instrument, just because I think you have a little bit more control of the suture material then. And Emily, how is yours going?
I think I did it.
Okay. Let's let Grant get that first knot in, and then I'm going to talk to you guys about what happens next. So and it is just one of these things that the more you practice, the better you get at it.
So during this whole thing, what do you do with the needle then?
So the whole time my needle is just sitting over on my sterile paper because I am only, so I use my hand when I'm doing my wrapping. So I don't even touch that needle. It's way over on that other side. So it's not going to poke me.
So I think I have them now. Yeah, I think I got the device because it's a real loose knot, right? It's not, doesn't
Yep,
actually
it's
secure
real
anything.
loose. Yep.
Okay.
So now we're going to tie the second knot. And when we're done with our surgeon's knot, we're going to have about 4 knots in it. So this first time I wrapped my string around my needle holder, I wrapped it to the right. Now I'm going to wrap it to the left. So I'm on my needle holder, but I'm wrapping it towards me now instead of away from me. Just once. We're only going to do one wrap. I'm going to grab the tail again and slip it through. So we want to alternate the direction that we're wrapping that suture material on our needle holders. That will help that knot. If we wrap in all the same direction, it's just going to form a slip knot.
So or grab, sorry, can you repeat that again? So
Yep. So the first time I wrapped my suture towards my computer screen. So now I'm going to wrap it the second time. I'm going to wrap it just one time away from my computer screen. So what I mean by that is I have the suture in my hand. This first time I wrapped it around towards my computer screen. Now I'm actually putting my needle holders on the other side of my suture material. So I'm wrapping it to the left side or towards me. And then I'll grab my tail and slide it through like I did. So now we have 2 knots. And then we are going to repeat that. So we'll go, I'm going to wrap a single time again to the right and grab the tail and pull it through. And then I'm going to wrap a single time to the left. Grab the tail and pull it through. And that's our suture. Then we'll trim the end. So there's like 2 millimeters left. So the first time we're doing the knot, we wrap twice. Every other time, we're just wrapping once. How is it going, Grant? You got a knot there? Okay, that looks good. And you're muted. I can't hear you if you're talking.
Gotcha. Yeah. Sorry about that. Yeah.
Oh, no
I
problem.
got that knot. So
Yep, that looks good. So we want to make sure we do it like 4 times. How is yours going, Emily?
I think okay.
Yep, that looks good. Now, like just looking at it, it's probably a little loose, like do
Loose.
about 4.
Yeah.
And so, and that's fine. But with your next one that you placed, you want to just make sure it's a little bit tighter. So if you guys do either one of you like you have to leave right at noon, or can I have a little extra of your time?
No.
yeah, I have time.
Okay, so then if you want to each practice one more of these, we can do that before we move on to the next stitch. Or if you would like me to just go on to the next stitch, I can show you that. But this is the most important one out of the whole workshop. So I just want to make sure that you both, understand this stitch and that knot, because this knot is going to be the same one that we use for any stitch that we place. Okay, and then when you're done with that stitch, you'll trim the ends so that about 2 millimeters of suture material is still there. And then we move that knot to one end or the other of the incision so that the knot isn't laying right over the laceration itself.
I guess in my mind, I'm thinking that this is a sterile procedure, so I'm like using my hands and like probably shouldn't do that. But then you have sterile gloves on when
You
you
have
do
your
this.
sterile gloves on, so you absolutely, yeah, so it is, it's kind of this weird thing mentally to think about, but your sterile gloves will be on, so you absolutely will be touching that suture material with your gloved hand. And then remember, like when we placed our first suture midline. To place the second one, we're going to cut that space to the left of it in half, and then our third one would be to the space to the right of it in half. It doesn't matter which side we start with, but then like our 4th stitch, we'll go on left side, 5th stitch on the right side. We're just going back and forth until it looks like it's closed well. All right, so I'm going to share my PowerPoint again because I'm going to talk about another type of stitch that is useful to have. We'll just practice it once. You won't get to be an expert on this one because it's a little bit harder. But tying the knot, I do have some nice slides on that, as well as written information on tying the knot for those of you who are more visual versus those of you who like to read it. And this is what that simple interrupted suture should look like when it's done. All of the knots are put to one side so that it's just, it looks nice. A simple running suture, we're not going to be practicing today. And our simple running suture is good for low tension areas. It's real quick. On the simple running suture, we actually start at one end and go all the way through to the other end. And it can look like a ladder, or it can look like a candy cane or barber pole, just depending on if you're advancing the stitch, either on top of the skin or underneath the skin, and either one is right. So the corner stitch is what we're going to practice next. It's also called the half buried horizontal mattress suture. And it's really nice if people have a skin tear. So if you don't already have like a little V-shaped cut, I'm going to have you make a little V-shaped cut because that's what we're going to use. And this picture just shows they drew a line right at the tip of where that V is, because we don't want to place any suture there. That would put way too much tension on the tip of the flap. The goal of the stitch is to secure that flap so that the tissue can survive it. And this photo, I think, shows it really good, where that we are going to do the first part where the suture enters the skin, just like we did with the single interrupted suture. We have under the flap there, it's going to be a subcuticular stitch, and it's going to come out on the left-hand side then. All right, so I have my V-shaped cut here. I'm going to just make a dotted line here, where that's the center of my V. I don't want to stitch there. And then I'm also going to put a dot off to the right side. That's where I'm going to enter the wound, and off to the left side where I'm going to exit the wound. So I'm going to load my suture needle into my needle holders again, the same way we did before, at that 90-degree angle with the tip of that needle pointing down. And now for this suture, in your other hand, you're going to want to have a forceps. Your pickups, because you're going to need it for this one. So I'm going to start by going in on that right-hand side. So my needle is over that laceration. I'm entering at 90 degrees, and I'm going to lift the flap so you can see here, my needle is actually coming through the wound here. So it's going to come through underneath the skin. So I entered on the top, I come through, and now I'm going to pull that needle through. And then for this part where we're going to stitch under the flap, I like to reload my needle, where now instead of pointing down, like before we were pointing the needle down, now I'm loading it where my needle end is up. So I'm going to lock that into place. With my flap, I'm going to do this pretty exaggerated, just so you can get a good look at it. I'm pulling this flap all the way back. And now I'm going to place a subcuticular stitch. I'm just scooping it. So it kind of looks like it's just in the mucosa. And then I'm going to pull it through. And you'll see here now, you can't see the stitch on the top of the skin. It is staying under the surface of it. I think that needle placement is really important there, where we're changing how that needle is. Now, if this is a stitch you do quite a bit, you may end up finding a needle position that works better for you. And some of this is just personal preference. So now what I'm going to do is I place that flap. So now I'm going to take the tissue on the left-hand side that is intact. I'm going to come in from the wound and exit. So I'm going to scoop it. So I was holding my needle once again with the needle point up. So I'm going to come in through the wound and come out of the skin. And then just like we did before, I pull on that long side. My needle is actually on the ground, on the sterile drape. I have my tail here and the long end, and I can tie a surgeon's knot there. And then I'll just cut the end of that. So on the sides of the wound, because this stitch, this corner stitch, really just does the corner, we could place that single interrupted suture, another one on the left side, another one on that right-hand side, or you might even want to use like a tissue adhesive to close that up there. But remember, this stitch, it's a nylon stitch and it's the absorbable type, or a non-absorbable type. So this one, they're going to have to come back and get that removed. And that is in the PowerPoint too, where it shows it. The other thing I have in the PowerPoint is right near the end is a video from Duke University that has all of these and more types of suture placement in there. And they talk about tying the needle, and it's just a great reference for you. So I would recommend that you bookmark that site or download it so that you have that. The last stitch I just wanted to mention, and I'm just going to show it. You probably aren't going to have time to practice this one with me, but you can absolutely practice it on your own, is that dermal stitch. Now, when I learned this, I called it an inverted mattress suture, but I don't think it has that name anymore. I'm just getting too old where things are not called what I learned them as. But this one, I'm going to do a little screen share because I want you to see on that PowerPoint, the knot is going to end up on the bottom of the wound instead of at the top of it. And it's great to give strength to an area. But you see on the left side here, how that's a simple interrupted suture. And that is showing the knot on the top of the skin. And for our dermal suture, it's going to be on the bottom. And I do have some nice slides here talking about that dermal suture. And another one that just kind of shows it's going from the dermis to the epidermal junction back to the dermis. So we aren't hitting the dermis at all. All right. So with this, I'm going to load my suture material, but again, here is where I'm going to load it, where my needle is pointing up. And you do need your forceps for this, where when you place this suture, we're going to go in deep and come out through the dermal epidermal junction. Pull that needle through. Oops, I pulled all the way through where I pulled my suture through. I'll place another one here. Pull it through, and then now I reposition my needle so that I'm going to go down into the skin. So I'm going to go through that dermal epidermal junction and go into the dermis. And now I'm just going to bring my tail on the same side. Okay, but there is my suture. And now I will just place my surgeon's knot once again for that one. So that was all of the sutures I wanted to show today. The biggest thing though, remember, is that single interrupted suture. So don't get overwhelmed with the other ones. I just kind of wanted to show them to you and show you that they're there and just the little different techniques for them. But that single interrupted suture is going to be the most important for you. And practice, practice, practice. If you have questions though, you can shoot me an email. I'm happy to answer any questions. But again, you're not expected to be an expert on this. Do either of you have questions that I can answer for you? Grant looks like he is busy putting in.
Yeah.
No questions then? All right, then you guys are free to go. Thank you so much for giving me some of your time today, and I hope this was helpful for you.
Actually, I guess I do have one question.
Yeah.
So like on one of my longer, the first interrupted stitch at the end, like how far do you go to the end? Do you go all the way to the end of the incision or the wound?
So you just want it so it's closed. Like I would probably go within, I would say again that 3 to 5 millimeter. So you don't want you want to stitch like right on the end of it, but 3 to 5 millimeters from the end.
So here's my question, I guess I have. So
Yeah, that
one
looks really
stitch,
good.
but there's like this little like open area of the
So
uh,
you could go either way. You could place one more stitch there. That wouldn't be wrong to do that.
okay.
But with having the rest of it closed, that's going to close up pretty nice on its own.
Okay.
Okay. All right. Well, I hope you two have a wonderful day. And let me know if I can answer any questions for you.
Thank you.
All righty. Bye-bye.
Thank you.
You're welcome.